Hello everyone, this is Dr. Humanist again. Let's discuss about Addison's disease. Addison's disease is nothing but a primary adrenal insufficiency. Okay, and there's something called secondary adrenal insufficiency. So differentiate that. See, primary will have hyperpigmentation. The secondary won't have. It will have, in fact, hypopigmentation, which is also called as alabaster skin. So it is a mineral which is white in color. And other thing you have to know that in primary what happens is the entire gland is not working. Okay, so even aldosterone is not there. So symptoms of hypoaldosteronism will be there. But in secondary there won't be aldosterone hypoaldosteronism. The aldosterone levels will be normal. Okay, so most common cause of Addison's disease in India is tuberculosis. In Western countries it's autoimmune, and most common virus causing it is CME virus. Fungal, it's histoplasmosis. Okay, some of the other causes in the primary adrenal insufficiency, using drugs, ketoconazole, etomidate, mitaropon, etc. Iatrogenic, if the removal of adrenal glands, and genetic causes like adenomyeloleukodystrophy. And in secondary, some of the like pituitary diseases, like pituitary tumor is there, or post-radiation, or an infection, or Sheehan syndrome, that is post-pregnancy, or head trauma, etc. Coming to the adenomyelodystrophy, it is X-linked. That's why the males are affected on the females, and it is because of the deposition of very long chain fatty acids in the adrenal gland. Okay. And there is something called Waterhouse-Friderichsen syndrome. As we all know, it's because of the Neisseria meningitis, that is meningococcal infection. In this, there is a abrupt onset and very severe. So we have to use drug of choice is IV hydrocot. It will be in the children, and plus the antibiotics like zone. That is ceftriaxone. Clinical features like because of hypoglycemia, patient will have fatigue, weight loss, postural hypotension because aldosterone deficiency is there. There is hyponatremia, hyperkalemia, acidosis, and loss of libido will be there, infertility because sex hormones are deficient. Investigation of choice is co-syntropin test, also called ACTH stimulation test. Drug of choice is hydrocot, and secondary adrenal deficiency, the drug of choice is dexamethasone. So this is the approach given the Harrison. So when the patient comes which is suspected for Addison's disease, like the history of weight loss is there, fatigue, postural hypertension or hyperpigmentation, hyponatremia, hyperkalemia, what you do next is you have to do ACTH stimulation test, also called as co-syntropin test. Okay, in this what you do is injection co-syntropin 250 microgram IM or IV. Okay, we have to give that, and after the 30 to 60 minutes you have to check the serum cortisol levels. Now if it's less than 500 nanomoles per liter, that becomes a diagnosis. Okay, because we are giving the co-syntropin, it should stimulate the cortisol more, but it's not stimulating that much production. Okay, other than that we have to see for CBC, serum electrolytes, RFE, thyroid test and all. Okay, now the next is we have to differentiate primary versus secondary. In that what you do is you have to do serum ACTH levels, plasma renin activity, and serum aldosterone levels also. What happens is primary adrenal insufficiency, the ACTH will be increased. There is increased activity, plasma renin activity, and decreased aldosterone levels. But in secondary, everything will be normal. ACTH, plasma renin activity, and aldosterone, all three will be normal. So in primary, you have to then see for autoimmune, that is adrenal auto antibodies. If it's positive, then we have to make a diagnosis autoimmune adrenalitis or autoimmune polyglandular syndrome, that is APS. Okay, if it's negative, you have to see the other causes like chest X-ray, serum 17, OHP enzyme, adrenal CT. Now if something comes out of positive, it can be tuberculosis or lymphoma infiltration, hemorrhage, or congenital adrenal hyperplasia, in which there will be increased levels of 70 HP enzyme. The treatment becomes hydrocot tablet we have to put in the patient. And if this is negative, all this test we are ruling out all the causes. Then if it's negative, then you have to suspect for and the patient, if the patient is in a man. Okay, so we have to suspect for adrenoleukodystrophy. Okay, in which there will be increased very long chain fatty acids in the serum of the patient. And if this is negative, then we have to again suspect for autoimmune only. And in the secondary causes, we have to see MRI pituitary. If any lesion is there, hypothalamic pituitary mass lesion can be there, which is causing that. And if the MRI is normal, MRI brain pituitary is normal, then you have to see in the history iatrogenic causes, like if the patient has put on steroids, some autoimmune diseases, and then patient stops it abruptly. Okay, that will cause ACTH failure. And then if there is a history of head trauma or is isolated ACTH deficiency, in that also cases the MRI will be normal. Now treatment in secondary causes is with tablet dexamethasone. Thank you.